Thank you, everybody, for coming today to this event. And you can see up there a map of the west side of Chicago here, and I'm going to talk about that in a second. But just a little bit about myself. I'm a doctor. I'm a primary care doctor, actually, and I'm leading the work at Rush in health equity. But I came to Chicago about 40 years ago, 39 years ago. I know I look a lot younger. But I came because in medical school, I began to see the differences in who got health care and why they got health care. And that really deeply disturbed me as a medical student. In fact, in that first year of medical school, I thought of quitting and becoming a forest ranger. I'm a tree hugger. But I stayed in medical school and met some colleagues, some friends, and we began to study the U.S. healthcare system. And at that point in time, we all decided that we were going to become doctors, but the large why we were going to become doctors is because we believed that healthcare was a human right. And if you believe that healthcare was a human right, then you need to be a human right activist as well as a doctor. And that led me and my friends and my lovely wife, who's sitting in the audience, to come to Chicago to train at Cook County Hospital. And Cook County Hospital in the 70s, it was a fight for whether that hospital would exist or not. And that was the subject of my first book, County, Life, Death, and Politics at Cook County Hospital. But in my career, I've been a doctor at 3 different hospitals, all within about a half mile of each other. I spent 17 years at Cook County Hospital in Chicago, one of the nation's great public hospitals, there to serve everybody, but not always with all of the technology and everything available at County. Then I moved a half mile down Ogden Avenue to Sinai Health System in the middle of Lawndale, which is the number 72 on that map, which I'm going to discuss in just a second. And then I wanted to go back to County, but they didn't have a job. I got recruited to Rush to be the chief medical officer. And my patients came with me. So I've had a personal experience of what it was like to work in these 3 hospitals, and my patients have had the experience. And then you take the step back and talk about the community experience. And I describe that experience as one street, 2 worlds, because in those 3 hospitals, on that one street, in those 2 worlds, you could discover, and patients could discover, everything that was right and wrong about health and healthcare in America. So that's really it was a stimulus for writing The Death Gap, How Inequality Kills. But now I just want to talk about this map a little bit, and then talk about some of my observations as a physician, but also I want to talk to you about Windora, one of my patients. You see where it says 85, that's where we are right now, in the Loop in the Gold Coast. Life expectancy, your ability at childhood to live a full life in the Loop gets you to the age of 85. If the Loop, Gold Coast, were a country, it would be ranked number 1 in the world in life expectancy. Think Japan. And now you take the L 7 stops. When we do this at Rush, which you can see as the hospital sign right there, it's 3 stops past Rush. Your ability to live a full life plummets to 69 years. And when I ask an audience, I'll actually ask this audience, why do you think this is? What's the cause? What is the cause of death that's driving this plummet? And if you think of this 69, you want to think of a country, think Iraq or Bangladesh. And just to put this in perspective, the gap along these 7 L stops between where we are now and Garfield Park or Lawndale is larger than the gap in the life expectancy between Haiti and the United States. So why is it? Any ideas? Wes? Okay, yeah. And many times I do an audience, people say violence. And it is violence of sort, but it's not the kind of violence you're thinking. It's actually structural violence. We have actually, so in this is perverse design. And I can explain it best. So this gap exists because the acts of violence that are occurring in these neighborhoods are actually hardwired into the rules and policies and procedures of our society. Now, we've seen it in this city and other cities around policing and how the police police. But you can see it in the way that the schools school, and you can see it in the way that the jobs exist, and you can see it in the way in the hospitals, in the care that the patients receive. I will just say to you that when I was a doctor at Cook County Hospital, I got a great training in medicine, but I also got a great training in social medicine. The idea that the kinds of things that are killing patients are actually upstream from the care delivery system. There are other things. And I went to Sinai. My patients came with me. And then they came with me to Rush. And it was only at Rush that I understand the power of the inequity here, the unfairness of the system. Because not only I was the same doctor, and the patients were the same patients, and yet in these three different places, what was available and what was possible differed. And I realized at that moment in time that it didn't matter. I used to think that, boy, if just people like me just showed up at these places, we could make the difference. But actually, we're not going to make the difference fully until we address the structural violence that underpins this. So I'm going to talk a little bit more about this, but I'm going to give you some examples. At Cook County Hospital, I went from being intern to head of general internal medicine, which is all the primary care physicians. And at Sinai, I was the chair of a department of internal medicine. And yet, in 27 years at those two institutions, not one of my patients who needed it could ever get an organ transplant. Even though the organs that went to get to transplant into people at Rush and Northwestern and UIC and University of Chicago came from the trauma units in these places. If I had a patient that needed a transplant, they couldn't get it. In fact, many of my patients died, not even getting access to a transplant list. At my 27 years at these two hospitals, at County in 17 years, not one patient who needed a joint replacement could ever get it. And at Mount Sinai, maybe one or two got a joint replacement. But Rush is a mecca for Midwest orthopedics, the best orthopedics in Midwest, private group. And if you have the right card, you can get your joint replaced in 3 weeks. The chief medical officer at County, I was on the board of the county health system, came to me one day to my office and said, "David, the wait list for the eye clinic at County is so long that you can go blind on the wait list. And yet across the street at Rush, you could see the eye doctor tomorrow if you wanted." Same doctor. So these inequities are hardwired to our communities and into our institutions that serve the communities and limit it's frank inequality. It's not even close to saying the care is equal at Mount Sinai as it is at Rush, literally down the street. I'm going to say another thing, because we're going to get to the core of this in a second. Not only does it affect the institutions and the doctors and nurses who work in these institutions, that would be bad enough, but it is absolutely true. And the way it affects the institutions, the capital dollars, what you build and what you can buy, has to do with how we distribute the money that comes from insurance cards. So at County and at Sinai, where there were poor patients who had, not the greatest insurance or no insurance, taken purely on mission, when it came to replace a piece of equipment, buy something, get a doctor who can do the procedure, doesn't have the capital. So the same neighborhoods that were redlined by the mortgage industry and by the federal government have been redlined and been forced to take vows of poverty that keep the patients from receiving the care they need, or the doctors from going to those places because you don't have the same degree of opportunity. But I'm going to say another, so the real thing is what is about the patients, and I'm going to talk about the community. So I'm going to tell you about Windora, and I talked about her in the death gap. And Windora has been my patient since I came to Cook County. So 4th floor of the old Fantas Clinic that's still standing, they're still operating. A hot summer day, I met her. And what was pretty remarkable about Windora and me is we were the same age. She had come from Birmingham, Alabama to Chicago, moved into Cabrini Green, and then moved into Humboldt Park. And I had come to Chicago, from upstate New York. And as primary care doctors and patients will happen, we became friends. I got to know her family. I got to know her situation. In fact, just last week, she was tragically in the hospital for one more time. But our lives were just divergent. I lived 3 miles away from her. She lived in a neighborhood of concentrated disadvantage. And this disadvantage in these neighborhoods, again, is something that didn't happen by accident. And her granddaughter got killed in the alley next to her. Just so much tragedy in her family that the way that she has aged and the way that disease has manifested in her is really beyond my ability to even influence it. And my realization was that the illnesses that she manifests come from the neighborhood conditions. So I want to talk to you about why it is the loop is 85, and Humboldt Park and Garfield Park and North Lawndale, there's that plummet of life expectancy. It's structural racism. So this is something that, when I talk about structural violence, we think of violence as being interpersonal or emotional violence, and it is. There's interpersonal and there's emotional violence. But structural violence is more deadly. This inequality kills as easily, as quickly, in some ways, as deadly as any weapon. And it manifests itself because of insults that occur over and over a lifetime that actually cause premature mortality. And the idea that in this country that you cannot live a long life because of the way that we've designed things. It's not like it rained on the west side of Chicago, not like a fairy dust blew over there. So you have to sort of, what's the inciting agent? And it's structural violence. And in this case, if you look at the way we layer our world by race in this country, the people who live to 85, think of a child born today in Northwestern Hospital, a little white child born in the loop, has the opportunity to live to 85, and yet someone born, a little child with the same potential in Mount Sinai Hospital will live to the age of 69 or 72. And so these are intentional systems that are hardwired in. And the great news about this is we can do something about it. But we don't talk enough about structural racism and the way that we've actually designed into our whole lives this layering based on race and other isms. It's not the only ism, because there's plenty of them. So when we look at Garfield Park, we say, what's wrong with Garfield Park? And we oftentimes focus on the beliefs and the behaviors and the biology of the people there versus the conditions. But we don't often focus on the loop. So what is it about the loop that informs us about Garfield Park? And I posit in the death gap that you can't have neighborhoods of this concentrated disadvantage without having neighborhoods of concentrated advantage. So what's happened in this country, actually, is we've had more exclusive neighborhoods of concentrated advantage that have sprung up in this nation over the past 40, 50 years that have then left behind these other neighborhoods. And to understand Garfield Park from a health perspective, because you could put all the doctors you want in this neighborhood, and we're not going to get to the health issues. It's economics, it's education, it's the way we've structured our healthcare system. But the concentration of privilege and advantage in the Gold Coast and other neighborhoods is directly responsible for the life advantage, disadvantage that you see in Garfield Park. And so there, in that situation, creates the potential for the solutions here. So I want to just talk to you a little bit about the way, so as a doctor, as a white doctor who came from a small town in upstate New York and didn't understand that, it wasn't until I came to Cook County Hospital and then to Sinai that I understood that the causes of the deaths of my patients, or the premature mortality, or the burden of disease, wasn't what they were doing, though of course, you shouldn't smoke and you should eat well. But as when Dora told me, she knew she was supposed to eat vegetables, but they're too expensive in her neighborhood. They lobbied to get a grocery store in their neighborhood. You mentioned the food deserts. She lobbied, but then when it came to get food, she couldn't afford it. Chris Rock, the comic, says the new Jim Crow is Whole Foods, because the $7 pear and green vegetables, fresh green vegetables, out of the reach of sort of poor people in this country. So not only do we have neighborhoods of privilege, and they often are white privilege, that have caused this. Actually, white people carry this privilege around them as if it's a neutral thing. Like my ability to rise as a leader in an institution, really nothing to minimize my ability, but why haven't other people had the same potential to rise? So until we begin to change the way our institutions look, until we sort of deeply reflect into who we are as a people and a nation, we can't actually begin to address the sort of the deep inequities here. I think there are, so number one, we got to call out our own privilege, not only as individuals, because we view this, I made it as a meritocracy. I went to medical school, I did my work, I did my things, but I can tell you the way that you have to look at racism through every single lens here, and to say, is there something about our institution that layers out by skin color? And is there something about our policies and procedures that advantage some over others by melanin deposits in the skin? So I had a discussion at Rush about institutional racism. And this was just last week with the chairs of departments. And I said, you know what institutional racism is? They all nodded their heads. I said, well, look around the room. The chairs are mostly men and mostly white men. So think about medical school. I'm going to talk about sexism for a second. Think about the equality of women and men in the first year of medical school, and yet look at what happens when you get to the leadership level. Think about who in leadership, that concentration of black and brown people in leadership. Because if you sit around the table, able to make the decisions or able to influence the policies, your own experiences are going to drive different sort of policy making. Think about Medicaid as we've heard the expansion of the Affordable Care Act. When we make Medicaid policies at a place like Rush, say Northwestern, University of Chicago, and we say we're not going to take this Medicaid policy, the lens of race, you have to ask yourself, well, who has Blue Cross, and how does that race layer out? And who has Medicaid? And I said to the chairs, our Medicaid policies a form of institutionalized racism, because if we don't take a policy, and it's mostly black and brown people who have that policy, then we're actually, it's a form of you know, segregation and imposed by policy. So we have lots of ways to begin to overcome this, and I hope in our dialogue we'll have a chance to talk about it more. But this has actually animated me to really sort of think, what do we need to do? And so these neighborhoods have been actively disinvested in, either intentionally or unintentionally. If the decision makers around the table are not thinking about this as a form of exploitation, then we're not going to get to solve it. But we need to look at these neighborhoods and the folks in these neighborhoods who've been differentially affected over now hundreds of years that require differential investment. And you know, what equity really means is those who need more get more. And yet we've designed a world that those who have more get more. And I'm just one final thing, and we're going to do part 2 here, which is dialogue. This has nothing to do with who's in power right now in Washington, D.C., except they're fascists and white supremacists and can make it worse. This has always been true. This has been true for 400 years. It's all local. It's our job to fix it. And I think with that, Harold invites you up, and we'll do the second part.
Thanks, David, very much for that talk. And now you brought in, you may notice that we're living in interesting political times at the moment, and that came up at the very tail end of your discussion. I wonder if we could start by maybe talking a moment about Obamacare or the Affordable Care Act. And if you could say some ways that you think it might help and some ways that you think it doesn't help in dealing with the issues that you describe in the book and in the 20 minutes that you laid out your main argument.
Well, you know, the Affordable Care Act did some good things. And, you know, I think you've seen the change even in this country with thinking about the opinions on the Affordable Care Act, given all the tumult over the last couple of months. But the Affordable Care Act, you know, I always look at things through an equity lens and through a structural racism lens. How does it layer? How does the implementation of a policy mitigate, reduce, eliminate sort of the racial oppression that's been part of this country's history? So I'm always looking for how does it achieve equity. So the Affordable Care Act was fantastic in many ways because it expanded insurance coverage, but it also left, at this point in time, about 28 million people uninsured. And if you just think about, well, what's the cost of that? Well, for every million people who are uninsured, there are 1,000 deaths per year. And so in the richest country in the world, the idea that we don't have something that's actually universally universal is a problem. It did cover expanded Medicaid, which for people who had no access to anything was a fantastic thing. And I saw many patients in my own clinic at Rush who got Medicaid as part of the expansion, whose lives were literally saved by having that card. And so, you know, I can say having an insurance card is, in anyone's mind, is way better than not having one. But it wasn't designed, it was designed to sort of say access to health insurance was the same thing as access to health equity, and it's not the same thing. So in my version of the world, we would actually have a single-payer healthcare system, which is improved Medicare for all, where no matter who you are in this country, that you can walk in the door, you've got the same card, because that at least gets to equality. Doesn't get to equity fully, but it does get you closer to equality. That said, you know, the good things was that we got many more people insured who were insured before. It was done in a way that was pragmatic and practical, because no one wanted to take on the insurance companies. But other than that, I think it fell flat. And so, of course, I'm against the Republicans' version of repeal and replace, but I am in favor of replacing it with a single-payer healthcare system.
One of the ironies of the current debate is in some ways it has certainly not ratified everything about the Affordable Care Act, but I think it has ratified two things. One is the idea that health care in some form is a right, not necessarily provided through single payer, but that people, if you're sick, you have a right to health care, and right to health care that doesn't financially punish you. And second, that Medicaid turns out to have tremendous support among both Democrats and Republicans, whereas the Obamacare market-based exchanges, it turns out, are orphaned in American politics to some degree, even though you might think that their free market orientation would generate more support among Republicans. It turns out that Medicaid is actually much more supported by Republican governors than these marketplaces are.
We're at very interesting times. I think everyone would agree with that. And I think it was very much clarified that we're in interesting times on January this year. But I want to just reflect on what you said. So one is this idea of health as a human right and health care as a human right. And that idea, and I think as you correctly said, this idea is getting traction in this country. Now it's gotten traction in many other countries way before the United States. There are 30 countries that have operated under that notion. Not only is it a human right, it's actually less expensive to cover everybody the same way than to do it in the crazy way we do it. But when you think about what does it mean to be a human right, one is once people believe you have a human right, you can't take it away from me. And that's even if you're a Trump voter in Kentucky, you can't take it away from me. People couldn't distinguish between Obamacare and the Affordable Care Act. But the idea that they now had insurance and the idea that you could take it away from someone, that's what a right means. And people are beginning to think that. To the idea that the big complaint that people have about the system has to do with the profiteering system of insurance companies and pharmaceutical companies we have that disadvantage all of us who have those cards. Now, the exchanges or the marketplaces, which put 10 million people on across the country, have been critiqued, but actually people conflate employer-subsidized health care with its high copays and deductibles with the marketplaces. It turns out 85% of the people in America who got marketplace policies were subsidized. And even sometimes their subsidies even extended to the deductibles. But my wife is a breast imager who trained at Cook County as part of her training. But imagine this. You get an essential health benefit, which is to get a mammogram. That mammogram is abnormal. Now you could possibly have breast cancer. Now to get the diagnosis and the biopsy, you fall into your deductible. That could be $5,000 for a family of four, $6,000. Maybe it's subsidized a little bit on the exchange, but if you're getting employer-based health insurance, that may not be subsidized. And now you have a choice. Do I get a colonoscopy? Do I get treatment for colorectal cancer and pay, like as a catastrophic health insurance, $5,000 or not? People are very, very dissatisfied with that. And meanwhile, the insurance companies have done out fantastically. So that is affecting Americans across all phases of life. And just to think about this fact of American life and its growing income inequality. So I said structural racism is a problem. I would say the exploitative nature of capitalism and the concentration of capital in the hands of few versus the many is a giant, giant international problem. And this is the fact from the Federal Reserve. Half of Americans, almost 47% of Americans, if they had to come up with $400 for an emergency, would have to borrow it or sell something to get it. So imagine coming up for your, the $3,000 for your breast cancer diagnosis. So that's a big problem with the health insurance writ large. Medicaid, in some ways, here's the Medicaid problem. Medicaid's a fantastic system. You get a card. The card has hardly any copays, no deductibles. You just can't use it everywhere. So the fact of Medicaid is that 1 out of 3 American doctors don't take Medicaid. And I can tell you at Midwest Orthopedics, in my lovely institution, Medicaid is like force-feeding a goose to make pate, because the orthopedic surgeons don't want to accept the Medicaid reimbursement. So the problem with Medicaid is 2/3 of American doctors take it, 1/3 don't, and then they face access to care problems. Now, if you hit bingo and your institution takes it and it happens to be a good institution, bingo, the Medicaid card works. But a lot of places it doesn't, and it doesn't pay correctly. Imagine your choice if someone put a $100 bill in front of you and a $1 bill. Any human being is going to take the $100 bill over the $1 bill, and that's how our insurance system works. And so Medicaid is fantastic. But in places like Chicago and other cities that have expanded, and Medicaid, actually more white people in this country are on, but it actually does, in places like Chicago, filter out by the color of your skin. So now we got structural racism. Whereas Medicare, you see health disparities reduced by race when you get a Medicare card, when people get on Medicare, because that card gives you equal access. Now, it doesn't make up for a lifetime of structural racism and the impact it's had on your body. And we know in Canada, with those kind of systems, you don't see the same kind of disparity. So there's many good things that happened. But the main problem, this seems to be rising to the top, is the profit-oriented, failed, flawed insurance system.
Well, let me push you a little bit on that. 2 issues. One is, if insurers were the problem in American health policy, we would have solved that problem a long time ago, because they basically pull with Bernie Madoff as far as their overall esteem in American society. The real problem in American healthcare in many ways is the supply side. And it's the institutions that you and I work for being 2 of the major players, where the prices that we are able to charge to a fragmented private insurance company system are very high, much higher than they can get from public payers. And they've been able to sustain that. And that is a big reason why the cost of health care is so much higher than it is in other countries. And I do think that, I'm not sure where I stand on single payer, but I do think that the demand side of the market has to be able to discipline our healthcare system in order to bring that about. So I'll let you respond to that first point.
Yeah, I think what you say is correct. I mean, if you think about it, there are a lot of special interests, and the special interests are not really in the same interest as, say, all of us as human beings and what we need, and there's a clash between that. And because the special interests include the physician organizations and hospital organizations and such like that, they're sort of lined up against the interests of the American people. Now, I'm going to tell you this is why I'm optimistic about that ultimately, and I think what you say is absolutely 100% true. But this is where I get...
We should stop right here, by the way. Go
yeah. We should say this is... But this is where I think American history is the real... it teaches us the lesson. And I like what Winston Churchill said about Americans. I don't know if he actually said this, but this is what he's ascribed to have said. Americans always do the right thing after exhausting every other possibility. And I just want to take you back in history a little bit. And I'm going to hold on to the idea that health care is a human right for a second. Everything that Harold says is absolutely true, and I would not litigate him on that. But hold on to health care as a human right and think about this for a second. You're an abolitionist, and you're talking to Abe Lincoln, one of our better presidents. He looks better when you compare him to our current one. But in Abe Lincoln's idea, abolitionists say, slavery is abominable, and liberties a human right. And yet Abe Lincoln would say, well, yeah, but we have it in these states. We should keep it this way. There are a lot of interests to keep slavery as tied to the economic engine of our country. All the slave owners, we have all these states. It's like half of America wants slavery. But the idea behind liberty, that freedom, there's a right, animated the Civil War and things like that, and where we are today. It's obviously, we're still litigating the idea of whether equality is a result of this. Think about women's suffrage. 70 years, Susan B. Anthony walked out in 1850 and inspired by the abolition movement, and a lot of interest about why should we give women the right to vote. They're not educated, they don't know, they should be subordinated to men. Listen, we haven't reached women's equality yet in this country, but actually the idea that it's a right for women, we actually wrote male into the 14th Amendment of the Constitution to say that that only men had due process under law. That was a poke in the eye of women, but we've evolved. The one I like to say, this is obviously, it's a big economic system, so it's different than the last one I'm going to talk about. But who imagined in this audience that we would have the right in this country, as a right, to marry the person you love? And think about President Obama's position on this. Oh, it should be a civil union. And people said, no, it's going to be marriage. So I think what I would say is you're right, you're correct, but you're wrong in the sense that we need to elevate this idea of a human right for health care. And that ultimately will lead us to what 30 other nations have decided, that one card for everybody. We have more than enough money in the system, but there will be winners and losers, should be the law of the land, simply because it's a human right. Because an insurance system, even Medicaid, is like it's not a right, it's more of a mandate. And a mandate means you must buy it, you must hold it, and of course the Republicans don't like that. But no one argues with Medicare. I'm going to say, there are people in here who have Medicare. Raise your hands. Anyone have Medicare? There are a few of you here. Do you like it? Do you like it? Yeah. Yeah, I've talked to people, vets. Any vets here or go to the VA? No vets here. We're too close to the light. You're a vet. Do you go to use the VA system? Anyway, vets in general, we criticize the VA system, but a lot of vets like the VA system. That's the British national health system. Medicare is Canada. So eventually I hope we'll come to our senses here. And the fact is, polling in the United States right now, the last poll, which was a few weeks ago, is that most favor a single-payer system. 100 Democrat reps have signed up, the majority of Democrats in Congress, for the bill on this. We have a long way to go, but
that would be, we could even do another hour on the obstacles to single payer. But I want to pick up on Medicaid for a minute to get to some of the issues in your book. It does seem to me, and all of the people that I work with in my work, everyone is on ACA Medicaid experience. I do a lot of criminal justice work, and basically everyone are young adult men who would have been uninsured 10 years ago and are now on ACA Medicaid. And it's great for them in a lot of ways. We are just at a learning stage of how to deal with population health. And one question I have for you is, given that map that you showed and a lot of the social determinants of health that are so different across that map, how can we use really the incredible amount of dollars that Medicaid and Medicare and other insurers bring to bear, even in these low-income neighborhoods? How do we bring that to bear more effectively to create greater health equity? If we say that healthcare is a human right and health is a human right, we are spending trillions of dollars through these systems, and we are not narrowing the disparities as much as we should.
Yeah, well, even in Canada with its own single-payer system, they have not reduced the gap. So I will tell you, we have a huge gradation based on income in this country of life expectancy, and that life expectancy mortality graph has diverged in the past 20 years. 25 years, whereas in Canada, it hasn't diverged the same way as it has in the United States. And so there's something about having a lifetime of care with the same card. I want to talk about fragmentation. So there's a number of ways in which there's having a card back then you're a young man and now you have a card, that's great because now you can begin to access things. But you know, what happens is we move between these different systems of care and different payer systems of care, and they're not integrated or coordinated in any way. And the enrollment processes and things like that have people falling off or coming on or not just getting it as a matter of birth. You know, you can get a Social Security card at birth. What seems to make life in Canada better for people is that, and even undocumented or immigrants to the country get it within a short period of time, is you have actually the same card through birth. So you have this continuity of experience with the healthcare system from early age. And what we do in this country is we have this sort of very jagged sort of way of doing it. There's zero coordination between the payers. So one year you could be, or 1 month you could be on Medicaid, next month you might be uninsured, maybe you get a job, you're now on an insurance, you now can't see the same doctor. So I think until we integrate these payers, and that's another advantage of a single payer system, we're not going to get to the real leverage that we have with population health. Yes, there's a lot of money in the system, but the money is not going in a coordinated way. And the last piece is one I talked about before. You know, a place like Rush or Northwestern can capitalize their facilities, University of Chicago, by preferentially seeking out good payers because of the vast margins, vast differential in the margins that you get. Medicaid, Medicare, big institutions actually lose money. So why would you actively go out and seek Medicaid patients? So a place like Mount Sinai, in the Death Gap, I talk about the 2012 or something. Mount Sinai, that serves these neighborhoods, had $6 million in capital. In Northwestern, both have trauma centers, had $273 million in capital. Under what idea or system of fairness would you say that that's okay? Do you know what I mean? And so, you know, the fact that people get Medicaid, and there are more people with Medicaid now at Sinai, so Sinai can keep his nose above water, is not the same as creating sort of equity or population health that you can do by leveraging all the dollars together. Because under a single payer system, the capital decisions would be made differently than we make them today. You know, you'd want to send your money to, on this map, if it was, you would want to send your money to Garfield Park in Lawndale and not to U of C, Rush, or Northwestern.
This might be, I certainly agree with that. This might be a good moment to open up for questions. So,
yes. I think
we have to follow we have a queuing discipline here, to use a U of C expression.
Can you hear me?
Yes.
Okay. I just wondered if you could speak to some of the divisions that may, and I say may because I don't know, that may occur within the medical profession around ideas about single payer, and also like when you're talking about the huge capital that, say, a Northwestern has compared to a Mount Sinai. I mean, who are the people who are making all these the gobs of money from these really overcapitalized medical groups, hospitals, and how do those people in that sector of the medical economy, how do they feel about reforming the healthcare system? I want to just add that it seems that whenever a physician is elected to Congress, it's always a specialist of some kind, and they're always very conservative Republicans. So I just wondered about the spectrum of thought within the medical profession regarding equity, structural racism, and I'm also wondering the response you've gotten in your own department when you mentioned that you bring up that issue of structural racism, but you didn't say how people hear that. So if you could start to speak to the diversity of opinion.
Yeah, I think so the question is who's making the money here? Is sort of, so follow the money. Capitalism is a very simple system. Capitalism exists to concentrate capital in the hands of the few. That's not I'm not making a moral statement about capitalism. Capitalism doesn't have a moral heart. And so capital concentrates in the hands of few. That's a fact. And the only way as a society, if we want to have capitalism, that you can manage that is by hyper-regulating the capitalists to balance out markets, right? And that's why we have these extremes of poverty in the United States. We're more impoverished in this country than we've been since the 60s. You know, there's more poverty here. There's higher income inequality. There's these death gaps that I'm talking about in Chicago, these are national. It's affecting white people now. It's a long-winded way to get to your answer, by the way. It's affecting white people now, and they're calling it disease of despair. Diseases of despair, because alcoholism, drug overdoses, you know, we're so animated about gun violence, which we should be. There's about 30,000 deaths in the United States from gun violence. There's about 55,000 deaths a year from drug overdoses. Now, when black people were overdosing them on the west side of Chicago, we never had this animation about drug treatment programs and police carrying Narcan. I'm not saying it's not the right humanitarian response to it, but I'm saying when it happens to white people in this country, we wake up a little bit. When it happens to black people, we don't talk about the diseases of despair. So I would say at the heart of all of this, you follow the money. There's, you know, obviously there's capitalism, but there's structural racism, even our response. But I want to get back to your point here. There are plenty of people who are making money on this, the system being the way it is. And it's always been an exploitative system. So it's not doing anything different than it's designed to do. And within that system, there are micro winners and micro losers. And it's just we've decided to allow that to happen. And it layers out by race and ultimately by income, who wins and who loses. And when I talk about it in the death gap, I do this thing about quality. So Medicare has ranked all the hospitals in the United States on a star system. 5 stars if you're good, 4 or 5 stars if you're good, 1 or 2 stars if you're bad. So it turns out that if the hospitals that are 4 and 5 stars, predominantly, they're the ones who you can say have capitalized enough to be able to do this, serve mostly white people. And who serves the 1 and 2 star? Who goes to 1 and 2 star hospitals? Mostly brown and black people. So there is lots of special interest. And you're right, the people who go to Congress are the ones who do this. But I can tell you, it's always been the same with every right that we've tried to get in this country. You're fighting against entrenched special interests who are making a lot of money. Listen, we still have slavery today if we allowed capitalism in the system, because it was much easier to produce things, and wage slavery. You know, May Day is tomorrow. And in Chicago in 1886 was the Haymarket Massacre for the 8-hour workday. So the fact of the matter is, yes, there's huge resistance. I'm a minority. I'm trying to convince people. My goal here is, listen, you guys all got insurance. I can't. I'm going to get Medicare soon, so I'm all right. But this is our, listen, this election told us anything. It's our country, and it's the power that we have to seize to do the right thing, right? So yes, I'm a minority. When I say institutional racism, imagine throwing a hard rubber ball against a brick wall, right? But think about this as well. I'm the first person at my institution to hold the title equity in my title. Guess what my job is? For the first time, my institution has realized, and the reason is, this isn't just bad for Garfield Park. It's bad for all of you to have a society like this. Do you think gun violence, the violence in this thing, the structural violence, impacts just you? When we were walking in today, we met on the street an unfortunate African-American man who was clearly mentally ill, very distressed. That's a risk, the consequence of mental illness, the stress, the structural violence on the lives of all of us. So I didn't answer your question, but to say is, I think about me as being an abolitionist, you know, in 1850.
I'm going to cut in, and I'm going to just, as the incrementalist guy who's telling the abolitionists to slow down and in Abe Lincoln's policy wonk shop. I did a lot of work for the Affordable Care Act on the public option. And it was very interesting to see how it played out. The official, and by the way, I'm optimistic that we will eventually get some ability for people to buy into Medicare. I actually think that the current political debate has increased the odds of that happening partly because people prefer Medicare and Medicaid to private insurance in a lot of ways. But I can tell you that when we were pushing for the public option, that a lot of the people who were with us on everything else, the people who were the good guys, the rural nonprofit hospitals who were pushing for universal coverage, who were pushing for the essential health benefit, for public health policies, said, and not so crazy about that public option thing. And places like Mount Sinai Hospital would be among the people that would be most nervous about it. And the reason that they would be most nervous about it is they would say, look, I've got a 62-year-old patient who's privately insured, and I need that revenue, and I need that margin. And if all of a sudden I'm across the bargaining table with Medicare for that guy too, in addition to all my Medicaid patients and my Medicare patients that I have now, I don't know if I can keep my door open. And we have a $3-point-whatever trillion medical political economy. And one of my real disappointments with Bernie Sanders in this last go-around was he really never told us, how are we going to get from here to there? Because it's not all white hats and black hats in this. Everybody, it's a very, very complicated set of politics and interests. And a lot of the people that really do need to take a haircut are the most influential people in the system. And the people who are the most nervous about some of these policy changes are actually very often the people that are the most vulnerable. And I think that one of the real challenges we have is how to incrementally reform our system so that we can get to that vision of healthcare as a right in a way that A, doesn't destroy what we have now, and B, actually works within a very dysfunctional political system. Right. And I can tell you that all the people who were the architects of the ACA, many, many of those people agree with all of the critiques of the ACA that you will hear both from the right and the left. And they're like, well, you know what, this is what we're able to do. Right. We should take other questions, because we went on.
Time for one more question in the back. Hi, my name's Sophia Castellanets. I'm a MedPeds resident at Vanderbilt in Nashville. And first, thank you for sharing your experience and your wisdom. My question is, at Vanderbilt, we unfortunately, in Tennessee, we did not expand Medicaid. As a result of that, Vanderbilt said on the outpatient side for adult patients, we will not be taking Medicaid or TennCare, which is our Medicaid product. The product itself is very flawed. For example, I can only prescribe 5 medications that will be covered per month for my patients who do have TennCare. But essentially, my question is, what do we start doing at places like Vanderbilt to move in the right direction of trying to get back to accepting these products?
Well, I'm going to answer your question by responding to Harold, and this is, but I'm going to respond to you. I'm not going to look at Harold here. So here's the thing: is I'm sorry about that, everyone. Incrementalism didn't work for many human rights issues in this country's history, and it's not going to work here. Because who's sitting around the table making these decisions for you and me and everyone else? And it's absolutely the wrong people. And I guarantee you, their melanin is mine, and their gender is mine, and they live in a community of concentrated advantage in which they never have to imagine what the life of somebody else's life. So this is all about power and political power and seizing political power. 2 is the lens of equity is the only lens to look at this through. So here's what do we do? In the last chapter of my book, The Death Gap, what do we do if the solution to ending racism isn't here today? And what do we do now? So you and I took an oath. It's one of the only public oaths you take. You get a public oath when you get married and a Hippocratic oath. Our job is to take care of patients regardless. And you, public, wouldn't want it any way else. Would you want me to check your insurance status before I start CPR or treat your cancer? Never. So you have an obligation with your own institution. I would guarantee you, you've got to call out institutionalized racism in your institution as show who are the patients who have TennCare. I wonder what poor white people too. But if we're preferentially serving the rich in this country, if that's the intention of our institutions, shame on us. And incrementalism, when people die at a rate of 1,000 per million for not having equity, I just can't accept that as incremental. I don't care who's at the table. And I do think so. We all have personal obligations. I hope when you go back to Vanderbilt, one is you stay in touch with me, because we all need to learn from each other how to do this. I'm having to discuss, when I was chief medical officer, I made our policy at Rush that Medicaid and uninsured patients could access our ambulatory care. I can tell you it's always a weekly battle to have our institutions not clamp down on people because of payer mix. And that's unacceptable from a moral reason. You didn't go to be a doctor for that reason. I say I'm a doctor and I'm a human rights warrior. I'm a warrior for human rights, and because until we have achieved the right to health and the right to health care as an entitlement, we have to go to battle. So I hope you go back to Vanderbilt and battle them and embarrass them and get the community activated to come to your hospital and demonstrate in front of it. Because without that kind of community engagement and activism, it ain't going to happen.
Let me just say a few things in response to that. No, I mean...
We make a good couple here, don't we?
Well, I mean, I actually think balancing the inside game and the outside game in American politics is critical. And you need warriors, and you need people who are doing the incremental politics, because incrementalism isn't a choice. It is not a strategic choice. It's the reality, it's the path open to us through which political change happens and legislation happens in the United States. That is, people didn't say, I think we should go for the ACA rather than a single payer because we sort of like, if we could draw from scratch, we'd like the ACA better. That is what we could do. Now, when we can do more when there's more warriors out there pushing. And I think making it clear to people how Medicaid harms people's care in a very visceral way. Doctors have a unique credibility in American society. Whether that's a good or a bad thing, we can have a whole discussion about. It is a true thing. And when you put a human face on TennCare and say, this is my patient, this is how he's not able to get decent care, people listen to that. And that moves people across the political spectrum. And that matters a lot. Yeah. And I think that pushing hard matters. I think you need to have, while you're pushing hard, you need people like David who are pushing hard and are the human rights warriors. And you need people like Nancy Pelosi who are saying, okay, how do I get up to 217 votes with something that I can do? And you need both sides of that. Because you need the Lyndon Johnson who can cut deals, and you need the Martin Luther King who is pushing and saying, no, I don't like your deal, you need to push harder. And they're both honorable paths. Now, what I'm afraid of, I think one thing we have to understand if you're a single-payer advocate, our single-payer system is going to have a lot of the defects that our current system has, because it's going to come out of our political system. And I think that the idea that there is this ideal healthcare system that we could just do, the problems are just a lot deeper in America.
And I know we have to end here, but I wanted to say this is narrative plus data plus community equals change. And so for all of us here, I write this book in a way to sort of engage and encourage and have people see the world in a different way. And I want to thank you all for coming today and actually listening to me, because that's something that never happens. But,
Well,